Hello and welcome to MedThinker. This is going to be a short summary presentation on the topic of heart failure. I am hoping that this will be useful to medical students at all stages during their studies, but also to final year medical students in preparation for their clinical exams. Please do let me know if you find these useful and if you think there is a topic I should cover in my next presentations. I am going to subdivide the topic of heart failure into the following chapters. I have put some timestamps in the description for you to be able to jump backwards and forwards as it suits you. So let's start. So what is heart failure? There are many definitions of heart failure out there. However, there has been an agreement just a few years ago in 2021 among different cardiology societies across the world on a universal definition. In this, heart failure is defined as a clinical syndrome, so a collection of symptoms and signs, along with structural or functional abnormalities of the heart that are corroborated by either high natriuretic peptides like BNP or proBNP, and or pulmonary or systemic congestion. Now this might sound complicated, but I am hoping that with the next few slides I will slowly decode this for you, and it will be actually much easier to remember most features of the disease just by remembering these 3 lines. When you see a patient with heart failure, you need to make sure that you clarify some essential information in the history. So when talking about symptoms, you might find that your patient has been experiencing some dyspnea, so they will describe that as being short of breath, and you will notice that they might have some reduced exercise tolerance. What does that mean? That means that they will become more short of breath the more exerted they are. Often, patients can present with orthopnea, that is being short of breath when lying flat, and that is why patients require to be upright in order to be able to breathe better. They might also experience paroxysmal nocturnal dyspnea. If we try to explain every single word in this very complicated sounding symptom, paroxysmal means episodic, nocturnal means at night, and dyspnea we already know is shortness of breath. So these are just sudden episodes of feeling short of breath that happen at night. So your patient might describe waking up suddenly feeling breathless. In addition, they might notice that they have some ankle swelling, maybe some weight gain, and sometimes they do feel bloated as well. In terms of examination, some signs you might notice could be a raised JVP, hepatojugular reflex, as well as some cardiomegaly. Depending on whether they are experiencing symptoms, then and there they might be tachypneic, they could be tachycardic, and when you listen to the bases of their lungs, you might hear fine crepitations. They could be cyanotic, and you might notice some peripheral edema as well. When it comes to the causes of heart failure, this sometimes becomes really confusing because there are very many things that can cause heart failure. However, by far the most common that you will hear about are coronary artery disease, uncontrolled hypertension, valvular disease, myocarditis, and then there are some other causes like infiltrative diseases such as amyloidosis, sarcoidosis, or even hemochromatosis, where these deposits in the heart make the muscle work not as efficiently, and then over time you can get heart failure. So thinking about how this disease comes to be, thinking about the pathophysiology of heart failure, in order to understand that we need to think back to the basic function of the heart, which is that of obviously pumping blood that is oxygenated to perfuse all organs. So in order to do that, the heart needs to be able to pump the blood out appropriately during contraction, And it also needs to be able to fill with blood appropriately during relaxation just before another contraction happens. Now, in heart failure, either of these is impaired, and so cardiac output is reduced, and this triggers a series of compensatory mechanisms that can put further strain on the heart. And we'll talk about this. So I have tried to draw a diagram of what seem to be the most important processes in heart failure. So I will try to explain this diagram. Now we need to start from the premise that, as I said before, something happens to the heart, which means that either its contraction or the relaxation phase of it, something goes wrong, and that means that the cardiac output is reduced. A consequence of that is that blood pressure reduces, and because the body perceives this lowering of blood pressure, compensatory mechanisms start. So we'll start with baroreceptors. Baroreceptors are those receptors that are present in your aortic arch or your carotid sinus, and they perceive that the blood pressure has decreased. This leads to a release in catecholamines, so substances such as noradrenaline, which are meant to lead to vasoconstriction. If you constrict your vessels peripherally, your blood pressure increases. However, that also means that your heart will have to work much harder to work against that vascular resistance, which is higher because those vessels have constricted. And this puts further strain on the heart, as I was saying earlier. These catecholamines also stimulate the posterior pituitary gland, and that leads to the release of vasopressin or antidiuretic hormone, which leads to fluid and sodium retention. That is not the only way that vasoconstriction, fluids and sodium retention happen. In fact, because of the low blood pressure that I was talking about earlier, the kidneys are hyperperfused, and that means that the renin-angiotensin-aldosterone system is activated. This, like I said, leads to vasoconstriction and fluid and sodium retention. Fluid and sodium retention means that there is a higher volume of fluid that the heart will have to pump out, and that means the heart needs to work harder. So we have an increase in both afterload and preload to the heart. The heart needs to pump harder because there is a higher volume of blood present inside it before each contraction, and with each contraction it needs to work against the vascular resistance, which is higher due to vasoconstriction. In order to improve the contractility, the muscle fibers grow in size, and so that is defined as hypertrophy. But over time, that means that the heart muscle stiffens. It grows and it stiffens, and that means that actually that relaxation is impaired. And again, we are in a situation where the heart cannot fill appropriately, and again, cardiac output is reduced. So as you can see, there is some sort of vicious cycle going on here with heart failure. And also, I should mention the last bit of the diagram that I think is important is that this exposure to catecholamines, renin, angiotensin, aldosterone, these are neurohormones. And we think that these lead to the remodeling of the shape and the size of the heart. Now, if we try to think about the consequences of having so much fluid and sodium retained within the body, as well as vasoconstriction, we will start to understand some of the signs and symptoms that we can highlight when we meet our patients. These two factors lead to an increase in the hydrostatic pressure in the capillaries, and when our patient has left-sided heart failure, so mainly characterizing the left ventricle, where the left ventricle is struggling to pump blood out towards the aorta and the peripheral vasculature, this pressure backs up from the ventricle back towards the lungs. And this causes pulmonary edema. This hydrostatic pressure pushes fluid outside of the capillaries, and this leads to impaired gas exchange. This explains some of those symptoms I was mentioning before, the dyspnea, the orthopnea, the paroxysmal nocturnal dyspnea as well. On the other hand, if you have right-sided heart failure, this will mainly present as ankle edema, and this is because the right side of the heart is struggling to pump blood into the lungs. This pressure backs up through the heart and back into the inferior and superior vena cava, but mainly due to effect of gravity as well. All of that fluid accumulates at the feet and it results in ankle edema, which sometimes can raise all the way to the knees and above, and sometimes patients can even get ascites, and that is where that feeling of bloating or weight gain and even into their abdomen, and that is where that feeling of bloating and abdominal distension and weight gain can be often noticed either by patients or by their relatives or by yourself when you examine them. There are a few ways to classify heart failure. However, I have chosen to include the two probably most important ones that you might need to know as a student, and those are, so the first one is a classification of heart failure in relation to the ejection fraction of the left ventricle. So very often you will see patients who are diagnosed with HFrEF, and that stands for heart failure with reduced ejection fraction, and that's defined as under or equal to 40%. Then we have heart failure with mildly reduced ejection fraction, and that is between 41% and 49%. We then have preserved ejection fraction heart failure, which is where the ejection fraction is over 50%. That is normal. And finally, we have heart failure with improved ejection fraction. And this is where someone who has normally a baseline of left ventricular ejection fraction of under 40%, so normally they have heart failure with reduced ejection fraction. However, on rechecking, we see that they have a 10-point increase relative to their baseline. And when we check it on a second measurement, their LVF is under 40%. So they are not quite in the category of mildly reduced EF, but it could be someone who used to have maybe 30% and now they are at 40%. The other classification that I chose to include in this presentation is the New York Heart Association classification of heart failure. And I've chosen to include this because this is very helpful in actually assessing the impact that heart failure is having on your patient. It is a functional classification and it classifies heart failure in terms of limitations to physical activity. So we have class 1, where there are no limitations to physical activity. Patients can walk distance without experiencing symptoms. We have class 2, where we have a slight limitation of physical activity, and that means that exertion will lead them to have symptoms of dyspnea and so on. We have class 3, where there are marked limitations, so patients will get symptoms on light activity, like for example walking a short distance of 50 to 100 meters. And then finally we have class 4, where we say this is severe limitation because symptoms appear when patients are at rest and also on any daily life activity. So as you can imagine, this is very, very debilitating in the life of a patient. If you think that someone might have heart failure, here are some of the investigations that I would like you to think about. So first of all, thinking about bloods, you will want to do a full blood count, and that is to check if there is any anemia and high lymphocyte. And these two are quite important because actually they are poor prognosis markers. UNEs, so you might want to know what their calcium and magnesium levels are, as well as their creatinine and their urea. We're trying to assess their kidney function. Here we're trying to assess their kidney function. We might then look at some liver function tests. Obviously, like we had mentioned right at the start of this presentation, we want to know what their BNP or pro-BNP is, especially if they haven't been diagnosed with heart failure before. We want to know what their thyroid function is and their lipids as well. We also, if they have diabetes, we want to know how well managed that is. So we will check on HbA1c. So all throughout these tests that we're ordering, we're trying to both assess whether this patient could have heart failure or not, but also we're trying to find a cause and any aggravating factors which may be contributing to their state. So in terms of some other bedside investigations, you want to carry out an ECG, and that will highlight any abnormalities in the electrical conduction through the heart. That could also point to the cause of their heart failure symptoms. And we also want to order a chest X-ray where we might see some very specific changes relative to heart failure. And finally on my list I have an echocardiogram. This is the investigation that is going to tell us about the structure of the heart, the valves of the heart and how well they are functioning, the blood flow through the heart and whether that is okay, as well as the function of the heart itself. So how well are those muscles contracting? Finally, the echocardiogram will also help us assess the ejection fraction of the heart, and if it is the case that this is heart failure, we can classify it as I've shown earlier. In terms of treatment, here I've put the list of medications that you will most often see patients on. So we have renin-angiotensin system inhibitors like ARNI, ACE inhibitors, ARB antagonists. We have beta blockers, aldosterone antagonists, and sodium glucose cotransporter 2 inhibitors. These are for long-term management of heart failure. When it comes to acute exacerbation of heart failure, you might see a slightly different approach. For example, you might see people being given diuretics such as furosemide. When someone gets a diagnosis of heart failure, it is very important to advise them about what changes they can make to their lifestyles in order to improve their health. And that advice might sound very similar to what we usually say to patients, but also some specific ones to heart failure. So for example, you want them to be monitoring their weight, and that will help us to monitor the heart failure. If they become fluid overloaded, they might notice an increase in their weight. That is unexpected. We need to advise them on sodium restriction, so trying not to eat as much salt or as salty foods, as well as stopping smoking and reducing or stopping drinking alcohol. Ultimately, improving diet and exercise is going to make significant difference, as well as making sure that hypertension and diabetes are under tight control in order to avoid that heart failure gets worse. Finally, in my presentation, I've also included some slides from the NICE guidelines regarding the diagnosis of chronic heart failure and referral to secondary care for specialist assessment. I must say that these are guidelines that are true to the month of October 2023, and the other one is on heart failure management, again with some both assessment in primary care and specialist reassessment. So do have a look at them if you find it an interesting topic. Other than that, that was it from me. Thank you very much for watching. I hope that was useful. Do let me know in the comments what your thoughts are, and I hope I'll see you next time. Thank you.